Hello and welcome to the Knowledge Translation webinar, Engaging with Audiences, a Learning Collaborative. My name is May Smith, and I am a Research Associate for the Model Systems Knowledge Translation Center. I will be the technical moderator for this event. Before we begin the presentation, I will take a few moments to review a few things. First, all phone lines will be muted during the event. If you have a question during the presentation, you can submit to the MSKTC through the chat feature. At the end of the presentation, you'll also have an opportunity to ask questions over the phone. If during our question session you'd like to ask a question over the phone, simply dial *7 on your phone to unmute your line. Please say your name and the model system that you represent. Once you're finished speaking, dial *6 to mute your line again. Once again, dial *7 to unmute and *6 to mute your line once you've spoken. Secondly, this event will be recorded and made available for review on the MSKTC website. Now I'm pleased to introduce Cynthia Overton, the Co-Project Director of MSKTC, who will introduce today's event.
Hi everybody, this is Cynthia Overton. I serve along with Cindy Kai as the Co-Project Director for the Model Systems Knowledge Translation Center. Thank you all so much for participating in our webinar today on engaging with audiences. Valerie and her team really have been hard at work to assemble a great group of our Model Systems colleagues who will share their experiences in engaging audiences. So we're really just looking forward to a very productive discussion that's sure to benefit us all as we work with our stakeholders. So thanks again for joining us.
Great. Thank you, Cynthia. So I will express my welcome also to the second KT webinar sponsored by the MSKTC. I'm Dahlia Shaywitz, and I'm the Service Area Leader on the MSKTC for Technical Assistance and Training on Knowledge Translation, or KT, Communities of Practice, and Consumer Needs Research. While this webinar falls under the heading of TA and Training, in fact, it builds upon the Model Systems' existing community of practice. We're excited to present this learning collaborative where model systems across all of the injury areas are sharing examples of successful engagement with different audiences or stakeholders. I'll be using those words interchangeably, audience and stakeholder. And while we're not going to focus on any one particular audience type, I do want to note that we'll be hearing about a variety of strategies to work with different audiences. So different strategies will work better with different types of audiences. It really depends on the goal of your engagement efforts. Next, I'd like to briefly introduce Tom Workman. He's one of our presenters today and a colleague of ours at AIR. He'll talk to us about how to measure the engagement of these stakeholders. And so, Tom, I just wanted to give you an opportunity to say hello.
Hi, this is Tom. Can you hear me? Hopefully you can. Good afternoon. I'm really delighted to be with you all.
Great. Thank you. I sent out a bio of Tom in our initial email. And, in fact, there were bios sent of all the Model Systems presenters today. So that's in the email that was sent out this morning. So we won't read all of their bios today, but you can learn more about your colleagues through that email. So today's webinar is planned for an hour and a half, and we actually have a lot to cover. I'm pleased to say we have 6 model systems who will be sharing information about how they're engaging with audiences. So today we'll begin by looking at some data that we gathered from the MSKTC survey of model systems from early last year. Many of you responded to that survey, and we'll share that data, and then we'll consider why it's important to engage with audiences, and we'd like to get your input on that question as well. Then we'll identify the types of audiences and ask our model systems presenters to share examples from their experiences. Then Tom Workman, who you just were introduced to, will provide some input to measuring the quality of engagement, what that looks like, how it can be done, and then we'll have a conversation around that topic. So the webinar is really intended to be interactive. We have some great scenarios that our colleagues across the model systems are going to share. Please feel free to ask questions or add your comments during those discussions. In addition, we have some time set aside at the end of the webinar during that discussion portion to share your experiences with consumer engagement and also to reflect on what you learned today. We really hope that everyone who's listening in will see themselves reflected in some of these scenarios, but also might see something new that you haven't tried before that you might like to. So we'd like to hear about what new things you've learned today as well. So let's begin by describing the audiences that we're talking about for this webinar. Patients, families, and caregivers, often we call them consumers. We also consider as our audience clinicians and practitioners, which include a variety of healthcare professionals. Policymakers are another group, and as Dr. John Corrigan pointed out to me in a conversation leading up to this webinar, these include not only elected officials, which is what I typically think of, someone at the national level, but they're also local and state government agency staff who are involved in policy making and policy implementation. And then we also have researchers, another group that the model systems are engaged with. We're not really talking about researchers during this webinar, but we do recognize that it's a group of potential stakeholders and collaborators. So here's what we know as of the beginning of last year about the level of engagement that the model systems researchers across all the injury areas are doing. And again, this was early last year. And at that time, we saw that when it comes to interacting or engaging with other researchers, reaching out to them, over 80% of you are actively or moderately engaged in some kind of outreach. With clinicians and practitioners, the outreach is even higher, with about 95% of you actively and moderately engaging this audience. And likewise with patients, over 93% of you are actively and moderately engaged in some kind of outreach with patients and caregivers. It's not surprising that the lowest amount of engagement is happening with policymakers. Less than 50% are part of your outreach or engagement. And that's an audience we'd really like to focus on specifically. But we're going to do that in another upcoming webinar. If you're interested, let us know and we'll plan that. We're also working on some materials to add to the KT Toolkit, which exists on the MSKTC website. So we've already begun to pull some things together to add to the toolkit. And again, we understand that strategies of engagement will differ with different kinds of audience types. But for the purpose of this webinar, we really just wanted to look at the variety of engagement and variety of audiences that you, the model systems, are already doing. So why engage with audiences? So why are we even talking about this? Why is it valuable? We've listed some common ways that researchers engage with various audiences on the slide, and I wonder if there are also other reasons why you would choose to engage with consumers, clinicians, and other stakeholders. And please feel free to either comment through the chat function or you can unmute your line. Essentially, we know that researchers involve consumers or stakeholders in identifying research or prioritizing it. And much of what you see on the screen you're going to hear in the model systems presentations in the next hour and a half. We recruit people for research studies and also ask stakeholders to provide input into outcome measures that we select, or maybe to review and refine questions and questionnaires. The idea being that the questionnaire should be useful to the end user. And that goes for products that the model systems are developing as well. And of course, we engage with audiences to increase the dissemination and use of the research, and also to help us identify barriers that stand in the way of actually implementing research findings in practice. Before we move on, I wanted to also look at it from the stakeholders' perspective. Some research has shown that stakeholders who want to be engaged generally have these reasons that are on the slide. They want answers to questions and research that informs their interest, and we'll hear a lot about that from our presenters. They're also interested in advancing scientific knowledge to contribute to the greater good. But the greater good isn't just about making the world a better place. It's also to be able to use what's going on with me, my involvement, how can I help another patient or family member. So these are people who really want to help other people. That's what that comment means. And then, so receiving financial compensation is not typically the reason that someone will participate in a research process, but not having it can often be a barrier to participation. So it can help cover a babysitter or transportation or someone to accompany them to a meeting. And for clinicians, it could be a billable time issue, providing enough incentive to cover their time. And oftentimes it's not only financial, it could be training or other kinds of materials that you'll share. So these kinds of motivations are good to keep in mind as you engage all of your audiences. It's really the what's in it for them. So now we're going to get started with the model systems and their presentations, which I think is why all of you are here. So I just wanted to whet your appetite a bit and introduce quickly, and we'll introduce them again. Dr. Radha Houlihan from North Texas will talk about building trust with burn survivors. Dr. Tessa Hart unfortunately can't be here, but I will be sharing her information with you from her slides. And she talks about engaging patients, clinicians, and caregivers throughout the research process. Bethlyn Houlihan will talk about engaging audiences in product development for patient advocacy. Jennifer Bogner will speak on behalf of OSU and John Corrigan and share her slides on using participatory engagement with her advisory council. Anne-Marie Kelleher, and I think Dr. Boninger might be joining her today, will talk about engaging users to test wheelchairs, but also they make a very good and strong point about creating a pipeline of researchers and other staff who have spinal cord injury or other disabilities. And we'll wrap it up with Phil Klebine, who will talk about developing a website with patients actively disseminating the website and the information to their primary care physicians. So, as our first model system presenter, I'd like to introduce Dr. Radha Houlihan. She's director of the North Texas Burn Rehab Model System, and she'll describe how she and her colleagues have invested in patient engagement from the start, building trust, connecting with national organizations, and involving patients in the learning process.
Thank you all so much, first of all, for giving me this opportunity to participate in the webinar. I would like to talk with how we have built a relationship with our burn survivors. Building trust with patients is a process and involves a lot of give and take. As researchers or clinicians, we love the process of engaging our stakeholders, knowing that the input of feedback we receive will benefit the work we are engaged in. But the question we also need to ask is, what is in it for them? How will their participation or engagement with us benefit them? Are they able to see or feel the impact of what we do? Does it improve their lives in any way? It's in the process of engaging with each other that we demonstrate how we can come together and work towards a common goal. What we have done at our burn rehab model system is that we've focused on building relationships and trust with burn survivors and their families at various levels through our local support group, through the national organization of burn survivors known as the Phoenix Society for Burn Survivors, and also through an international organization such as the Changing Faces in the United Kingdom, which is, this is an organization dedicated to help people change the way they face disfigurement. This kind of engagement has helped to build trust between burn survivors and the researchers. We have engaged consumers in surveys to determine the relevance of research topics to burn survivors and their families. We've created a peer support training opportunity, and that involves burn survivors and their families as well. We also have several burn survivors serving on the advisory board of the model system to provide feedback on research and other model system activities. Who is involved? We have our burn survivors here at the local level and their families, and then we also have the Phoenix Society involved, and they collaborate with us on several of our activities. And James Partridge, he's a burn survivor who actually started the charity organization called Changing Faces in the United Kingdom. We also have invited James Partridge to our model system to come and speak to our burn team which includes the faculty and staff of the burn team, including surgery and physical medicine and rehabilitation residents, the therapy students from physical therapy and occupational therapy, and we also have burn survivors attend that presentation, just to show that we kind of work as a group and we are constantly engaging with each other in setting goals for ourselves. We have also collaborated with the Phoenix Society for Burn Survivors to develop an online version of their already existing in-person social skills training. We are involved in evaluating this online training program, and it's part of our research agenda for the current cycle. We also have burn patients and returning burn survivors who are engaged through our advisory board. They review our research topics, they provide peer support training, and also serve on the panel for various educational programs for nursing students. What are the stakeholders doing? The researchers provide support group members with a list of potential study topics, and we ask survivors to provide their input and feedback on the relevance, usefulness, and applicability of those topics. In some instances, they even offer new topics that they feel is a common issue that should be considered. As a result, we have been able to identify more pressing issues for these individuals, such as social skills, community reentry, heat sensitivity, etc. In addition, we also have patients and family members who would like to serve as peer support volunteers. If they meet certain criteria and they are screened by a psychologist, and we have a standardized peer support training program. This is a training program set up by the Phoenix Society. It's called the Survivors Offering Assistance in Recovery. The program covers a variety of topics such as how to work in a hospital setting, the role of the peer supporter, what are their boundaries, what can they do and what should they not do, their communication skills, and also to learn about the process itself of psychosocial recovery for burn patients and their families. I'm also certified as a peer support instructor by the Phoenix Society, so we work together in identifying eligible families and burn survivors to participate in this capacity. We also have staff members trained as coordinators for this program. These are physical therapists and occupational therapists, nurses, research assistants. They serve as coordinators, and what they do is they facilitate the face-to-face peer visits in the burn unit, and we work very closely with the peer volunteers and the burn survivors and their families. So, another thing we did was we actually utilized the help of our burn survivors to produce a very short video. It's a 10-minute video entitled In Their Own Words. This video captures some difficult situations the burn survivors deal with in their everyday interactions and how they overcame those challenges. The video was presented at the Aftercare and Reintegration Forum presentation at the National Meeting of the American Burn Association, and this was done 2 times. The second time it was actually requested for. The link of this video can also be found on our university website, and I'll be more than happy to provide that at the end of this presentation. The video was received very well, even at a postgraduate course, which was entitled Improving Social Reintegration Outcomes Through Empowerment of the Burn Survivor. So we are able to relate the messages that our burn survivors want to give to people like us who are working with them to make this process a two-way kind of a process where we are helping them and they are helping us with their information. How will we measure the effectiveness of the intervention? The model system is studying the effectiveness of several projects, including the Phoenix Society's online program for social skills and the Changing Faces program. It's called 321-GO, and the results of these studies are pending. The 321 program is used as an intervention study. Subjects are randomly assigned to a training group, and with the control group that does not receive the social skills training and the experimental group that receives the 2-hour training. Both groups are tested for social interaction anxiety. And then the Phoenix Society's program, the online social skills program, is also part of our model system site-specific project for the current funding cycle. The goal of this study is to test knowledge, practice, and health outcomes following the social skills training. Additionally, we use the input and feedback on other possible research topics. This kind of provides us an affirmation that we are moving in the right direction with our research activities. We also have a quarterly newsletter that we publish, and this newsletter is has the information that we have actually received from our burn survivors that they consider is most relevant and most important to them. We actually invite our burn survivors to contribute to this. They submit their experiences and recovery processes and success stories. These surveys that we also conduct with them based on the readership, we ask them if it's useful to them, and that way we kind of gather feedback regarding what might be useful and what might they want to see in our future publications. Realizing that we are willing to sit and talk with them, learn what information actually helps them, and then include that information in a way that's useful, helps to build trust between the patients and the researchers. What are dissemination plans? The model system likes to continue. We engage with burn patients even in dissemination of information to other consumers. The value of having someone who has survived a burn injury to share information is much more powerful than offering information from even the most empathetic researcher or clinician. We have published findings in newsletters. It serves as information that burn survivors may use for themselves or family members. They also bring it to our support group and discuss what is presented in there, and they also use that with their peer support visits with the other patients that are still in the unit. The model system, again, periodically sends out a survey to solicit feedback regarding the utility of these newsletters, as I just mentioned. We are also engaging with, collaborating with the other model systems and with the MSKTC to develop fact sheets. And the fact sheets are also, they provide usable information to the burn survivors. And so what we do is we kind of provide that as an information base for our support group and our advisory panel to kind of tell us what topics they might be interested in, and so we start working on those topics to produce fact sheets that would be useful for them. We solicit input from the advisory board members. We have several burn survivors participating in that regarding how we can make our resources more accessible and how can we deliver information that's relevant to them and how they might be able to use it. We have, the model system has used the Phoenix Society's annual World Burn Congress also in the past for data collection for some of our research studies, and so we have engaged with burn survivors on a national level. And when we've published the findings from that data, we've gone back to their meetings to present the results in a usable format for the survivors. And we have also invited burn survivors to participate in several panel discussions, and they frequently come for participating in educational panels for nursing students in their training program. We do have challenges that we face, but we constantly strive to work towards overcoming them, and we do seek the help of our burn survivors and their families. We have heard that our consumers also express frustration that we do not have the types of information that they are looking for. Sometimes there are relevant and interesting materials produced by the Phoenix Society as a burn survivor organization that may not be distributed by the professionals in their burn centers because these products are not validated by research, and there is some kind of, apprehension in giving out information that is not validated. But survivors often tell us that they don't always want to wait for research to be conducted on the information they need now, such as social skills or community reentry. We can't keep telling them we haven't validated it by research, so we'll have to wait. That's something that really frustrates them, and we have heard that from our survivors more frequently than ever. What we are trying to do is, by collaborating with organizations that make that kind of information available, we want to collaborate with them to build that bridge where, it's kind of validated and tested at our local institutions, and we are able to have some data to say that, yes, this works. Another challenge is connecting with hard-to-reach consumers. We know that some survivors live in isolation, not exposed to available resources, and it's difficult to determine here what issues impact them and what topics they are interested in receiving information on. It's getting better, but we still have to be able to reach out, and we have to come up with various mechanisms to reach out to this hard-to-reach population to be able to help them. Another challenge we have is the direction in which we need to move is looking at the long-term outcomes of burn injuries and aging with burn. We would like to lead focus group discussions with this population to hear their concerns, learn how they're coping with their injury years later as they're aging, and what some of the long-term outcomes are, because research now has just barely begun to tap on aging with a disability, especially with the burn survivors. So we are working towards it, and we feel that by building this relationship with our burn survivors, we will be able to help them with what they need. And that brings me to the end of my presentation.
Oh, wonderful, Radha. Thank you so much. I've heard this and I've been reading it, but it's still fresh to me because it's a very difficult population that you're trying to engage with, and I think as one of the most challenging is probably the best example and a great way to start off the webinar. Are there any questions from anyone on the phone? You have the option of typing a question into the chat feature, and we'll read that for Radha, or you can press *7 to unmute your phone and ask your question out loud.
This is Bethlyn, Houlihan. I have a question.
Wonderful.
Radha, you mentioned that you have folks that you said are hard to find. They're not system connected. And you said it's getting better. I just wanted to hear a little more about that and how you're able to find those people and get them connected.
We are able to, I wouldn't say we have great success stories there. That still remains a huge challenge for us. But the way we are trying to get better at it is with our relationships with the Phoenix Society for Burn Survivors. Somehow we find that a lot of burn survivors learn about the Phoenix Society and their national meetings each year, and we've seen that the number of attendees at the World Burn Congress, which is hosted by the Phoenix Society, actually the number of attendees have increased over the years, and so we feel that more and more people are getting to know about Phoenix Society. And by us, with our relationship with Phoenix Society, we are hoping to get that link there and that help to reach out to consumers through organizations that are doing a better job of reaching or are able to, and even sometimes it's the other way around. The community is reaching out to organizations that are, solely, they know that they're representing them, and so they are trying to reach out to them. So we're trying to go through other avenues apart from trying to make ourselves more informative and trying to disseminate more locally. We are trying to get to know other resources as well, where we can establish this link that will enable us to find these patients or survivors who are lost in the community as far as we are concerned.
Great. Well, thank you.
Okay, great. If there are other questions, please jot them down and hold on to them. We'll have, I hope we have some time at the end to ask more questions if you have them for Radha. And thank you, Radha, again. That was a great presentation.
Thank you.
And a wonderful way to start us off. What I'd like to do is connect what Radha was telling us, and you'll see that she followed a certain outline. Most of the presentations follow that outline, and it's really this stakeholder engagement process, which is a visual representation of the general research process, and it shows in this model how stakeholders are engaged along the way. So there are opportunities where you can engage your stakeholders, particularly patients and caregivers, throughout the process. They might be involved in helping to select or refine your research question or your research approach. They might provide input into the relevance of your study to their lives and their work. There's a great value added also to asking patients and clinicians to look through data, because they often identify different kinds of conclusions than the researcher does. Sometimes stakeholders are engaged in the conduct of research itself through participatory action research. They also can be involved in the data analysis, and they can co-publish the results, the publications, either co-authoring a report or reading it for plain language. Stakeholders can also be a tremendous help in disseminating your research findings or your research products. And we know that all of you are doing some of this. And some model systems in particular are engaging their stakeholders in really innovative ways. We'd like to share the range of stakeholder engagement that we learned about in preparing for this webinar so that you can also learn what your colleagues in the model systems are doing, have an opportunity to ask questions, and maybe even consider how you would like to try one new type of stakeholder engagement based on what's shared with you today. So I have the pleasure and both pleasure and disappointment. Pleasure of introducing Dr. Tessa Hart, and the disappointment is she wasn't able to join us for this webinar. But these are her slides, and I'll present them to you. Unfortunately, I won't be able to answer your questions about them, but I strongly encourage you to reach out to Dr. Hart if you do have questions or if you want to contact her with any comments. So I'll share these with you. First of all, when designing a study, the Moss Rehab researchers conduct focus groups with stakeholders to learn the answers to the questions you see on the screen. What topics are important to their consumers? What's important about a given topic? Would consumers like to see a different topic addressed, or what would they like to see addressed in that topic area? And is it feasible, and are there barriers to success in conducting that kind of research? And the research team also surveys stakeholders to learn about more general topics or areas of interest. And the Moss Rehab team has different stages of research development in which they try to engage individuals. It's been a challenge for them to identify individuals, form a group, and bring them together. So instead, what they do is they connect with existing groups of patients who meet regularly. This could be a brain injury support group that meets at the center, or it could be a clinical group meeting as part of an outpatient program. And then the researchers will request an opportunity to talk with the group members about topics that are important to them. And the discussions often begin by sharing the research and the ideas that the model system has been working on, and then they continue by asking consumers what other kinds of topics they should be looking at. And that keeps the researchers in touch with what's important to individuals who have a traumatic brain injury. And what are those stakeholders doing? Sometimes the research team has a specific topic in mind, so they'll ask very pointed questions about a proposal or activity. For example, when the team was developing a project on using text messaging, they wanted to learn whether people with traumatic brain injury use messaging, in what way, and what were the barriers they faced. And what they learned from the patient support group was interesting. First, they learned the proportion of people who use text messaging, so how many people are actually doing this. And then they learned that there were a lot more people who would like to do it, but they just couldn't afford a phone. And they didn't realize that the cost of a phone could be a barrier to patient use of text messaging. They also found that older people in the general population, but also in their TBI population, do less texting because they're intimidated. So as a result, the researchers stipulated in the project that if participants did not already use text messaging with a cell phone, they would first design a training program to show them how to do it, and then provide a pay-as-you-go phone if they needed one. So the stakeholder input helped the team to design a project to help people who were not already using technology to do so. The Moss Rehab traumatic brain injury model system works with consumers of information, and that includes patients, caregivers, and clinicians, in a variety of other ways to gather input, review materials, or gain insight. They conduct focus groups. In fact, they conducted focus groups on an inpatient project on pain measures, and the patients were not always able to tell them whether or not they were in pain, so families were able to confirm that it was an important topic to study because they could see that their family members were in pain, but the patients weren't always able to voice that. So not only did the family members buy into the project topic and agree it's important, they also encouraged the team to continue that line of research. And then they asked, the research team asked nurses to give input into the scale items that were included, and family members also shared ideas and refinements for the scale. Through pilot studies and discussion groups with clinicians, the research team reviewed the MOS Attention Rating Scale, MARS, to create and then weed out items. And since clinicians are the ultimate users of MARS, their input was really important and substantial. And then the research team also went to professional conferences and distributed questionnaires to clinicians outside their institution to get feedback and to find out if the tool was helpful. The research team recently conducted an interview with a patient to talk about traumatic brain injury, to walk through a manual they created as an intervention for depression and anxiety. So the patient provided feedback on whether the information made sense to him, if the wording was clear enough, if the right information was emphasized, and they did a tremendous amount of revision to the manual based on his input. And they said it was particularly important to have a male input into the issue of depression and anxiety to make sure that the language worked for men as well as women. And finally, she shared that the research team piloted a questionnaire to measure outpatient services, and to make sure that the patients understood the questions, they asked about the type and quantity of outpatient services received. They got feedback from patients and reworded the questionnaire based on that feedback. Okay, in terms of dissemination plans, the MOS Rehab group, research team conducts a one-day conference each year during their model system cycle to provide education and networking opportunities for people with a brain injury and their family members. They spend an entire year devoted to just planning this conference, and they involve consumers as fully as possible. So consumer input helps them to determine the topics, but they also have workshops that are planned and conducted by both clinicians and consumers teaching side by side. She mentioned that they also facilitate seminars for consumers in rural parts of Pennsylvania, and they developed a toolkit because it was so popular to help consumer groups plan and run their own seminars on a more regular basis, since the research team didn't have the resources to be able to do it as frequently as the consumers would have liked. And then in terms of challenges and solutions, we did mention earlier that they had a challenge with forming new groups, so the solution for that was to connect with groups that exist. Dr. Hart mentioned that while there are challenges to engaging clinicians due to time constraints, and it's also sometimes difficult to encourage them to systematically use research findings in their work, she's found that they have not faced a lot of barriers to engaging those clinicians in the research. She said they're very motivated to participate, particularly in the tools, and she's also found that the patients and caregivers are very interested in sharing their ideas and opinions. So these are the slides for Dr. Hart, and again, I'm sorry she's not here to answer questions that you may have, but please do reach out to her. You can find her through the MSKTC website. If you do a search for Dr. Tessa Hart, you'll find her email address and information about her center.
All right, thank you, Dahlia. Next, I'd like to introduce Bethlyn Houlihan, who is the Associate Director for New England Regional Spinal Cord Injury Center. Bethlyn will talk with us about a project she's leading called My Care, My Call, that engages a variety of stakeholders throughout the development of a patient's self-advocacy product. Bethlyn?
Hello, everybody. So My Care, My Call is we needed to engage stakeholders to try to develop and test. We were trying to come up first with something that we thought was going to be useful for people and that we could manage to do with the community. And we're trying to see what was something that was going to be needed by the community, and just started with, based on some other projects we've done, we started with looking at primary care and recognizing that this is just a huge issue in general. I'd been at a conference for the National Spinal Cord Injury Association Summit. They held a national conference, and this was a whole workshop that talked about this issue. And so we were just looking at it in the first place, just trying to understand, all right, is this worthwhile? Is this something that people want us to look at? So that was kind of the premise, and we'd had some background conversations first when we were in proposal development, as Tessa Hart presentation was speaking to. So we ended up coming up with this and developed this in the hopes that we could create it so that it would be useful and have an impact for people and really speak to their lived experience. So that's kind of where we started from. And in order to do that, for the sake of developing this, we wanted to try to help people, train people to advocate for themselves when they're working with their primary care provider to get their needs met. So that's kind of what we came up with. We looked at training and had a hard time finding a way to train providers and get to the right population and package the training in a way that would be efficacious. And we're still working on that. If anyone has ideas, we'd love to talk with you about it. But we ended up developing a content expert panel that had stakeholders that vetted all the projects and all the ideas that we have for the project. So we used people with spinal cord injury from different backgrounds. We had some experienced physical therapists, social worker, rehab commissioner, representative from the state. And so we developed a panel at the onset once we got going with this project. And we included buy-in from United Spinal and an NSAIA. So we have the director of their resource center is actually involved in the project because they would like to be able to offer this by the time we're done with it to their chapters, their support groups, their hospital members, wherever it makes sense, assuming that we actually are able to show that this will work with people. So that's part of where they're involved all along the way and can provide input based on what they're seeing every day and the calls coming into their office and the ways they've managed to navigate through the system and help people navigate. So we can use all those people to try to help us develop this so that it is actually useful. The first thing they've done for us, the first thing that they did was really help us to flesh out what are the major themes, what are the things that are critical to consider as you're doing the work on the ground with people. What do you think are the things we need to make sure that when we're all done with this, we have covered, that we want to kind of keep as our guiding principles and our guiding considerations as we're working to develop this. So we did that. We had phone calls every other week and did some quote-unquote homework in between and really hashed this stuff out. And it was very exciting and lively conversations, very dynamic. And now they are working to review and provide feedback on scripts that we're developing that are going to be conversational scripts that really they can be, even though it's an automated system that we're working on, these scripts can be very personalized in a lot of ways, bring people down to pathways based on responses they've given before and based on what they're saying within a given call. So we will run through that with a person, with one of the expert panels on the other end of the phone in a live test format, so that they can give their feedback right then before we even finish developing a script, so that we can make sure that it is taking into consideration anything we haven't thought of that panel of 6 people have thought of. And then we're going to, in the end, after we're done with that and have pulled all the scripts together and created the system, we're going to pilot test that with 8 consumers from different backgrounds and do qualitative interviews with them to get their feedback, revise the system, and then do a randomized controlled trial with 60 individuals. Obviously, 30 will get the My Care, My Call intervention, and 30 will receive just their standard care. So what we're trying to do to really test how effective this is, we're going to, through the randomized controlled trial, we'll be getting at outcome measurements at baseline and 9 months. So people are going to be in the trial for 9 months. And we are hoping to see that the My Care, My Call telehealth module will increase their self-advocacy and their healthcare interactions. And there's 3 domains that we're looking at: self-advocacy, assertiveness, illness education, and their ability to, if they choose to be mindfully non-adherent. And that will be compared to those getting usual care. These are all validated instruments. We're also looking at those as people to say, is there something when you look at these that you just think they're not capturing that we need to throw in there anyways? Because a validated instrument is really useful on one hand, but on the other hand, you want to make sure that we're capturing things that are meaningful to people, even if it's not necessarily validated yet. And then our second hypothesis is trying to look at increasing people's sense of self-efficacy for healthcare navigation. So we're going to look at that compared to usual care as well, and how much they prefer to be involved in and are satisfied with their primary care provider as well. So, and all those are from validated instruments, as I said. So we have a whole bunch of ways we're going to try to look at how this is effective for people. We have ways that we can just look at the contact logs of how often people interacted with the system, the pattern of any calls. They can call in if they want to. The system will call out to them, but they can also at any point call in. So we'll see how often they do that. We can see if they choose to hear more content when they can hear it, and how they rate the calls, so we can get any ratings they want. And then we'll also look at, the characteristics of different types of people and what that tells us about how often they're using the system. From previous experience in another project, it seems women tend to call in more than men and use the system a little more. And we'll look at dose response, and we'll also do some exit interviews where we really ask some more in-depth questions from a breadth of people that were adherent, that weren't adherent, different backgrounds, to just understand their experience with it and how they felt about using it, and so that we could make it better. And hopefully we're doing a lot of that on the front end with this content expert panel, but that would also be able to see some of this and with the pilot testing, but we also want to capture it on the back end too if we can. Next slide, please.
There we are.
All right. So we are looking to work with the expert panel to participate in presentations themselves, so that they will be able to bring this out to the groups that they work with in their networks. And we'll also do that through our Consumer Advisory Board. And they'll be helping us with writing articles, helping us with being able to do presentations. All of that will be part of what they continue to stay involved in, since they've been involved from the beginning. And they'll also help us vet anything that we create, fact sheets or any reviews that we create that are more consumer focused. They'll help us to vet those materials and just make sure that one, that they're really consumer focused and from lay language and clear, and then they'll also help disseminate those to the networks that they have. And we are hoping that if it works, obviously United Spinal and NSCIA is looking to be able to get this out to folks, and we would want to try to offer it as a package as best we can to community organizations nationwide. So we want to continue to build those collaborations wherever we can. But those are the basics for the dissemination plan at this point. And that's going to continue to be an iterative process in working with these organizations to see what will work best for people as we move along. Last slide, please.
Okay.
And as we've been doing this process and working, really engaging these panel members, and we also have, I'm focusing on that, but we do have many other channels that we're using. We have our Community Advisory Board that we're using. We have other key stakeholders that we'll just talk to and do individual interviews with. But focusing on this content expert panel, I think the biggest challenge to just constantly have in mind is their limited time and availability of everyone. These are people that are out and about, very active in their professional lives and as advocates in their personal lives. So we had to really just be sure that, and talk through with them as we went along, that we were chunking the tasks out and making everything really meaningful for people and chunking out the work in a way that was reasonable, and at the same time so that something will be accomplished within a 30-minute phone call. And that their homework in between was going to take them, that 2 weeks in between was only going to take them an hour at most. And even in the calls, we had to be able to be very democratic and say, I can talk with you more about that offline if you want to. Right now we need to move into this discussion before we're done. I want to respect everyone's time. Just really being careful about that for everyone, and then following up and having the conversations that you needed to with other members to keep them engaged. So that was very important to do along the way too. But that kept it for the entire group shorter. And we also found that it was, if you by honoring that time and honoring people and really hearing them too, we found that people wanted to stay engaged. They just continued to say, you've done what you said you do, and I want to, what's going on with this? I want to stay involved. They just feel it's important. They feel like we're hearing, and that everything they're telling us, that we're bringing that back into the fold and using that as part of it. So it makes a big difference for people, I think, when they feel like you're actually listening to what they're offering, and that they can see that in how it's being conceptualized and how it's rolling out in the design. So I think that's all that I have. So I really appreciate your time, and I'll take any questions.
All right, I think we have time for just one question, if anyone has it. Otherwise, we can wait until our discussion session at the end. Thank you so much, Bethlyn. That was great. We're looking forward to seeing the results of your efforts through your dissemination of the final tool. All right, next, I'd like to introduce Dr. Jennifer Bogner, who works with Dr. John Corrigan at the Ohio Valley Center for Brain Injury Prevention and Rehabilitation. Dr. Corrigan could not join us today, so Dr. Bogner has kindly agreed to present information about their use of a participatory model for their advisory council. Dr. Bogner?
The Ohio Valley Center established the Ohio Valley Center Advisory Council over 20 years ago. We were first funded through an RSC, U.S. RSC grant. That was a multi-state grant that was aimed at improving the lives of persons with traumatic brain injury and improving services up at a regional level. So we included the states of Ohio, Indiana, and Virginia and West Virginia in that initial grant, and built the advisory council as part of that grant. In 1997, we became a model systems center, and we continued the advisory council as part of our work with the Model Systems Center, as well as some other projects. And during that time, we also added Michigan to our state representation. Currently, we meet with the group at least twice every year, and in person, and then we also meet by phone, or and we also communicate by email in between meetings. Who is involved? These are people who are actively engaged in various activities to improve the lives of persons with traumatic brain injury. It's a dedicated group. We really would not have been able to do many of the things that we've done without the input from these individuals. They include people with traumatic brain injury, as well as secondary consumers, family members or other people who care for people with traumatic brain injury, advocates, representatives from the State Brain Injury Association, as well as the National Association, the Brain Injury Association of America, clinicians, and policymakers. The policymakers, as was discussed before, are staff members from state government agencies. Most often the RSA, the Rehab Services Administration, or the Health Department have been our primary representatives from the state. Many people who've started with us started out with a strong interest in improving what services can be provided to people with traumatic brain injury, and then they have moved on into engaging in even more active roles in their state, depending on where their level of interest is. If we can go on to the next slide.
Very good.
What are the stakeholders doing? It's participatory action from the beginning of the idea for the project to dissemination. They work with us right from the very beginning, and they help us all the way through providing input. It starts out with what we call an envisioning process, and this occurs with us every 5 years. The envisioning process is a group process that takes 18 months to complete. Each part of our advisory council meeting devotes at least part of the meeting to that process, and in between we oftentimes have email communication as well, or phone conversations, depending on what we need to do. What we're doing is trying to get a bird's eye view or a big picture view of where the field of traumatic brain injury rehabilitation research is in terms of where the current needs are of persons with traumatic brain injury, what still needs to be done to address those needs, what's currently being done. And we get input from our advisory council, but we also bring in invited speakers, we host panels, we have other group meetings to stimulate the thinking and ensure that indeed we are capturing what that bird's eye view is. And then after the advisory council has gotten close to the end of the process, where they've identified what the needs are and what our priorities are for the next 5 years, then we refine it down and we identify what's going to be doable for our particular center. And that's where John and I and the rest of the folks involved at the Ohio Valley Center begin to refine our research plans or our project plans. We've had different areas of focus as a result of this envisioning process through the years. We have 2 areas that we've focused on most consistently through the years: substance abuse as well as the study of long-term outcomes. They're currently studying traumatic brain injury as a chronic health condition. But the focus has also changed through the years in terms of some specific areas. So, for example, the Advisory Council identified back in the 90s the need to look at involvement of persons with traumatic brain injury in using the Internet. And so we had a couple of projects involved with that. We developed several different listservs that are still being used today by different groups within the brain injury field to communicate as part of that process as well. Just as an aside, my email address is bogner.1, and that means I was one of the first people at Ohio State to get an email address. And I think we all thought we invented the Internet way back when. So. Anyways, we became very involved in that, and then as the interest started to wane there, and or because other projects were being successful in that area, we started to turn our focus to other areas. The Advisory Council indicated we should be focusing, for example, on the military and other topic areas. The Advisory Council is also very much aware of the fact that, as we start down a research program or a project, a program of study or a program of development, that we're a fairly large boat that can't be turned around very easily, and that it takes a number of years to get projects to a point where you're producing some products that are effective. So we can't turn very easily. We have to finish our work in an area before we can move on to some new areas sometimes. And of course, then there's also issues with funding, etc. But they help us with that. They help us with identifying where are the most important needs, and that helps us with looking at the funding sources more carefully. The Advisory Council also helps us with the work of the center. So not only are they helping us decide what our focus should be, but they are actually actively engaged in the work of the center. We have 2 different subcommittees, the Research Committee, which I lead, and then John leads the Annual Evaluation Committee. And both of those committees are very active committees. The Research Committee meets in person once a year, but then also meets periodically by phone throughout the year and does some communication by email as well to help us with guiding our research projects. Just as an example of how the Advisory Council works, at the last meeting, the Research Committee met in the morning, and we went over the findings from local project for model systems from the previous funding cycle. I went over the study results with them, and then they provided me with input in regard to how to interpret those results, but then suggested some additional analyses that they thought might be helpful as well. And then I presented some new projects that they had previously helped to develop in terms of ideas, and I presented what the initial research plans were for those projects. And they helped with giving some additional input in terms of ways to effectively implement those projects. So we were looking both at an old project and where to go from here, as well as some new projects and how to best implement them. And then in the afternoon, the full advisory council met, and we were looking at developing developing ideas for knowledge translation for caregivers and using statewide systems. So what we did there is we got their input through another group process, smaller groups, and got their input in terms of what different caregivers might need in terms of information and resources, and what's currently available, and what are the most important sources of information or pieces of information that different caregivers might need. And then the next day, the Brain Injury Association of America updated the group with the latest happenings on a national level. And then we went around to each of the members of the different states, and they updated the group in terms of what was happening in each of those different states in terms of the brain injury efforts. So throughout that weekend, we weren't doing the majority of the talking. Actually, the people doing the majority of the talking was the advisory council, and it was highly interactive. While we do sometimes bring in, do some presentations and those types of things, most of the time when the group meets, it's a highly interactive process and not a lot of talking at, more likely talking with the different people in the advisory council. And then in terms of dissemination, we use the states, our state representatives, to help us with finding the best ways to disseminate our findings to the consumers. So we use the state conferences. We're often invited to each of the different state conferences as well as national conferences to present our findings. We also use webinars. That's been one of our more recent avenues for disseminating some of our findings, and we've really appreciated the Brain Injury Association of America's methods for doing that. We've done 2 webinars with them this year. And then we also provide summaries of our research projects to the Brain Injury Association, where they publish them on their website or in the challenge. And our research committee helps to make sure that those abstracts are written in a way that they're accessible and consumer friendly. So in terms of how did we get this started, and how did we keep this advisory council going? Well, it's one, we were just incredibly fortunate, and we continue to be incredibly fortunate that the people who participate in the advisory council are willing to give their time and their energy to meeting with us and providing input at various points. That's critical. And we've found that we've had people who have stayed with our council all the way through all of the 20 years. I think there's 6 individuals who've done that. But then there's also been new folks who've joined the conference through the years. And it's critical, I think, that we have the continuity because our programs of research do build on each other. And as we get one study done, the next study is a natural continuation, and it helps to have people who have that history to help with ensuring that we stay on track with those. But then also bringing in the new folks and having the new, fresh ideas is also important as well. So having both is important. In the beginning, when we first started the council, what we found was very important is to allow folks to tell their personal stories. This helped the council with getting the context where that person was coming from. But then as they became more comfortable with the council and with their participation in the council, it turned from talking about personal stories to talking about what's happening in the state and what's happening at the national level. And that's really where our segment for the advisory council meeting called News from Home came from, is that it's a recognition of the fact that we need to know exactly what's going on in each of the different states. That's how we all learn from each other. Communication is incredibly important, as you would say in almost any context. We try to have in-person meetings at least twice a year. That depends part on funding. We've managed that, I think, through most of the 20 years. I think there might have been 1 year where we had to skip the second meeting. We also use conference calls relatively frequently to supplement those meetings, and then some less frequent emails also occur as well. But the most important thing is that it's interactive, that it isn't us sharing information with them as so much as we're sharing information with each other and giving each other feedback on the different areas. And then we devote staff resources to this. We have one person who is the primary contact person for the advisory council members that helps with organizing the meetings and helping to ensure that travel goes smoothly for everybody. And then each of the people who are involved in the Ohio Valley Center, from the program director to the director, becomes involved in the meetings themselves, helping to lead different panel discussions, et cetera. In between the meetings remains actively involved.
The OVC's work with their advisory council is particularly interesting because all of the model systems have an advisory committee of some kind, and all are using this committee's input in different ways. What was most striking for us was the intentional engagement of policymakers in the advisory council. I'm going to jump right into the next presentation by Anne-Marie Kelleher and Dr. Mike Boninger, who are with the University of Pittsburgh Model Center on Spinal Cord Injury. They will share with us an interesting look into the participatory engagement of wheelchair users at their center, where users recommend, test, evaluate, and disseminate tools that are developed by the researchers and engineers.
Thank you for the opportunity to share ideas on this topic. As part of the UPMC SCI team, we conduct research and development activities to improve the design and function of wheelchairs and other assistive technology devices using a participatory action design format to engage consumers in the process. We currently have about a half a dozen studies that use focus groups and questionnaires to get consumer feedback on design and development activities. We involve consumers at all levels. Our multidisciplinary team includes researchers, data collectors, rehab counselors, a psychologist, and numerous graduate students who all have spinal cord injuries. Participant recruitment depends on the type and stage of development of the research project. We often involve both end users and clinicians who are responsible for AT provision. Participants are recruited from our rehab facilities, numerous local events and expos, as well as annual events that we attend nationally, such as the National Veterans Wheelchair Games. In addition, our team has developed several research registries to help us identify people who use the type of technology we are developing. The registries were established in 2002 to help maintain contact with former participants and to list potential users who may provide feedback on specific topics or projects. Registries are compliant with privacy regulations, and people are contacted on a regular basis to update information, share research results, and receive quarterly newsletters of which they're encouraged to provide feedback on projects written about in the newsletter. In the research process, end users and other stakeholders are engaged at each phase. Our multidisciplinary team benefits from learning about the challenges end users face firsthand. We have conducted questionnaire studies to get feedback on design concepts. For example, we will show 3D drawings of an early prototype with a description and ask end users for feedback. Would a person with SCI use this product? And if so, how would they use it? And what are the recommendations to improve it? This helps our research team to know if we are on the right track. We also conduct small focus groups with about 8 to 10 people that meet certain eligibility criteria and would benefit from the technology under development. At this stage, we often have a prototype that was made or modified by our in-house prototyping facility. Participants can try it out and then we'll ask in-house, and then we'll ask a series of questions to tease out what they like or dislike about the product. We use standardized questionnaires to get objective information as well as ask the person their their feedback as well, subjective comments. Then we go back to the drawing board to incorporate any changes. Often in the next phases of our studies, researchers will conduct a more in-depth evaluation, such as biomechanics testing. The in-lab testing ensures the devices are useful in a structured environment. Then we typically move to in-home testing to ensure the devices are functional and useful in the real-world home environment. For example, individuals with spinal cord injury will take the device home, use it for a few weeks, then return to the lab and provide feedback, questionnaires, and one-on-one interviews. Consumer feedback throughout the phases of design and development help to improve the effectiveness of the technology. Feedback and input provided after testing is measured and incorporated into further stages of development. And again, this is dependent on the objectives of each research study, but can include standardized questionnaires, clinical or research assessment tools, and interviews. The ultimate goal of many of the technologies is increased participation. So therefore, participation and quality of life measures end up being the most important outcomes evaluated. The next step in completing a product is dissemination. And in addition to peer-reviewed research journals and publications, our research team makes every effort to distribute lay abstracts and articles to consumer-oriented publications, such as Paraplegia News. We've developed several consumer-oriented clinical practice guidelines for Paralyzed Veterans of America and also the MSKTC. Research team also disseminates information about our research results to over 2,000 newsletter recipients and registry participants. And in addition, researchers give presentations about the research at events held by local disability organizations and support groups. We also have staff members with SCI host a peer support group, which is also a great way to share information and engage consumers. A challenge for our team has been coordinating routine logistic issues. Individuals with disabilities tend to have issues with transportation or may need caregivers to assist them. The research team really needs to be dynamic in reaching out to these individuals with spinal cord injuries. One of the other challenges is for us is learning what is the best way to use social media to communicate with people. How are people using it? And I understand that this can be maybe a whole topic in and of itself in the future. So we're definitely interested in learning how other people are using this as well.
Thanks for sharing this information about a very participatory model of engagement of end users of products. Moving on, there is one type of stakeholder engagement that is very much outward-facing, the use of audiences to help in dissemination of research and information. The University of Alabama Birmingham SCI Model System has recently developed a website to share information with primary care physicians about SCI. I'd like to introduce Phil Klebine from UAB to share the new website and explain how it is being used. Phil Klebine works at both the SCI Model System and the TBI Model System at UAB. Phil?
Thanks very much. Let me apologize for my voice. I'm a bit under the weather today, and thanks to the MSKTC. Let me start by saying I've heard a lot of great work going on around the country, and most of the consumers around the country probably don't have an idea of people like you who are out there and working to improve their lives. But they may have an idea that you're out there, but they don't really have an idea of the dedication and effort that this group is offering. So as a consumer, I just want to thank all of you for the work that you're doing. This is some really exciting stuff going on. As for this presentation, I think everyone can agree that there's a great value in the services of community-based primary care providers. Our PCP manages our general health issues and provides the necessary screening for potential problem issues. Our PCP can also refer us to specialized care if necessary. Of course, patients with spinal cord injury or traumatic brain injury, for that matter, remain in need of those same primary care provider services following injury. And ideally, they would rely on their PCP for managing many of their secondary medical issues associated with injury. However, I'm sure many in this audience have shared in the frustration of patients when failures are exposed in the delivery of those PCP services. Many of these failures stem from a provider's lack of knowledge. In Star Trek terms, the primary care providers are trained to manage the needs of the many, not necessarily the needs of the few patients with spinal cord injury or traumatic brain injury. The inherent problem there is that the patients are those who ultimately deal with the consequences of this. On the first slide there, I can just say here at UAB, we're doing a number of things that kind of mirror what I've heard today as far as engaging the audience, but specifically here, we are developing 2 new websites to more effectively meet the educational needs of the primary care providers. First in spinal cord injury and next in traumatic brain injury, for each website. And each website is to be a one-stop location for finding available clinical practice guidelines and recommendation for conditional medical management. We will also provide situational advice on when referrals to specialized services is warranted. On the screen, you'll see a capture of our SCI website for primary care providers. This is in development, and here you can look at the front page. We have a conditional information completed for bladder and autonomic dysreflexia right now, and we're adding new sections as we develop them. On the next slide, here you can see a look at the inside page for bladder dysfunction. There is information offering an overview of the condition and links to other internal pages that we have with information on those specific topics. We also provide resource links at the bottom of each page. There are submenus on the left sidebar there, you may be able to see that, where there are patient handouts doctors can click on and find information that they can give to the consumers. On the right sidebar there, we have UAB's toll-free medical information service, which is a 24-hour hotline for physicians to consult with a UAB professional. One other thing of note is that we have now reached an agreement with the Paralyzed Veterans of America, the PVA, to provide a summary of its clinical guidelines where we need it. This allows our website users to remain at one location and eliminating some of the time-consuming tasks of linking from website to website to find information. Finally, on the last slide, the plan here that we have for dissemination purposes is to go live with our spinal cord injury website this upcoming fall and the traumatic brain injury website next year. Once we go live, we're going to take a bottom-up and top-down approach to getting the information out there to promote the website awareness and use. We plan to empower consumers by offering a wallet-sized card. And you can see just something I put together briefly there on the bottom right-hand side of the page. We're going to offer a wallet-sized card that they can carry with them and provide their medical professional as needed. For our top-down approach, dissemination approach, we are targeting localized professionals here directly through advertisements in state medical magazines and newsletters. And we're also working with the MSKTC for a similar targeting effort to reach the medical professionals on a national level. And I did hear one thing that My Care, My Call that was described earlier. I think Bethlyn was working on that. Perhaps we can work on something together and maybe get some more information and maybe widen our approach to this and get more information out there to consumers.
Great, thanks, Phil. And one thing I like to do is encourage a lot of conversation, but we're running so short on time that I'm going to ask people to hold their questions and contact the presenters directly. Thank you for the suggestion to collaborate with Bethlyn. And we really look forward to receiving information about the websites when they're complete and they're live. So I want to quickly thank the 6 model systems who did such a great job of sharing their engagement. I want to move us right on to Tom Workman. I'll bring him back onto the line to speak with us about measuring the quality of engagement with these various stakeholders.
Thank you so much. I'm really delighted again to be with you. And what great examples of engagement. Really, congratulations to all of you for really capturing the concept so well in such great variety. We had created in February, had published in Health Affairs, a conceptual model of consumer and patient engagement specifically, but really applies to all of stakeholder engagement that looks across three different levels: engagement in direct care, engagement in organizational design, engagement in policymaking. We are creating a specific one for research, but it fits quite often in the organizational design and governance. But really what I want to pull your attention to is the continuum of engagement that goes from the left-hand side to the right-hand side. Because when we think about engagement, we really are talking about various levels of involvement. And that can range from consultation on the far left side all the way to full partnership and shared leadership. Several of the examples that you discussed today are great examples of shared leadership. In other words, the decisions that are being made about what to study, about how to study it, about what the final product should look like, what the program should look like, was shared with your stakeholders. And so that's where the far end of engagement. What we want to talk about, though, quickly is how do you measure this? And I'd love to tell you that we have a tool for measurement that is completely finished and validated, but we don't yet. This is something that many people in the field are working on. But we do have some understanding about what we're looking for and what we're going to ask about, and so that's what we're going to focus on. So two things I'm going to suggest is in measurement. First is the measurement of process, and the second is the measurement of outcomes. And really what we're looking to ask here is, did we accomplish the level of engagement that we had planned? So in other words, if in our model we had decided we just wanted consultation, did we achieve it? Or did we want full participation? This is critical because, in fact, sometimes we think we're after full partnership, but we wind up just getting consultation. In other words, we have an advisory group or advisory committee, but we simply feed them information and then just get their okay, as opposed to, as some of you discussed today, really involved them in the decision-making and had them raise the key agendas or the vision for accomplishing what the group wanted to accomplish or what the center wanted to accomplish. So we want to first measure by process, and we want to ask key questions in process that helps us decide whether the stakeholder was able to fully engage and if the role was appropriate for the project. So three ways we can do this. First, we can review procedures, and we can see, was the stakeholder fully informed? Was the stakeholder capable of participating? And I really appreciate a number of your examples that talked about capacity building for your stakeholder as a key component, because oftentimes this is part of the process. We engage in decision-making that the stakeholder is not capable of. And so really looking at what we've done in our procedures to help them feel capable, have a very clarified role, and able to give input. The second is a review of the decision-making process. How was the stakeholder input incorporated in decision-making? Did they have an equal say? Were they involved in decisions? Or were they simply informed of decisions that were made based on their input? So we'd want to look at that process. How did we actually make decisions with our stakeholders? And finally, there's this issue of stakeholder satisfaction. Several of you mentioned it in your own measurements, and I think it's a valid measure because we want to make sure the stakeholder themselves feel that they were able to participate, they were satisfied with their role, they understood their role, and were clear about that role. Of course, the second measurement that's equally important, if not more important, is the ultimate outcome. And here we're going to ask a very simple question. Is the end result a stakeholder-centered outcome? And again, that might be a stakeholder-centered research project, or that might be a stakeholder-centered decision or process or policy or service or dissemination plan. One of the speakers mentioned, and I want to really raise to all of our consciousness, this idea that stakeholders were able to see their input in the final project. They could actually see what they had suggested reflected back to them when they looked at the final report or the final project. And this is really what we're after in terms of outcome measure. Is this what, and the term that we're using far more often these days is it stakeholder-centered? Is it reflective of the involvement of the stakeholder themselves? This raises some key questions that we can be asking with our audiences as we're engaging them, and ask ourselves as we're trying to evaluate the quality of this. Are we reaching a level of engagement that is most appropriate for this project? And did we accomplish the level that we were shooting for? And again, we find this continuum is a little bit helpful for us to think about it in this way. And I should say all levels of that continuum are valid. There are times when we might just want consultancy, and there are times when we want full involvement. So we want to think about that as much as we can. Did engagement yield a stakeholder-centered outcome, as I mentioned? Do the stakeholders feel satisfied? Do the stakeholders feel their interests and ideas are reflected? Do the stakeholders feel a sense of ownership in the outcome, particularly important? And are the stakeholders fully activated? In other words, are they now even more able to participate in the future as a result of this work? So if you go to the last slide, I simply have given you several Likert scale agreement survey questions that you may want to add in your evaluation using the basic Likert scale, and these are levels of agreements. Agree fully, don't agree at all. They just give you some ways of measuring these. Now, I will tell you these are in the validation process, so these are not yet validated. In fact, your involvement with them can help us do that, and I'm excited for that opportunity. But you can see that some of these really try to get at this both process and outcome element, and so surveying our stakeholders is one approach to do that, as well as doing general process evaluation.
Sure. If there are questions, please unmute your line and feel free to ask them. We see one from Gretchen Carruthers. What exact Likert scale are you using, Tom?
This is 5 points. This is
great.
A 5-point Likert, and it's an agreement scale. So, fully agree, fully disagree. Fully agree, somewhat agree, null, somewhat disagree, and fully disagree.
Great, thank you. Any other questions? We did want to have some more discussion and reflect on what we heard during the presentation, but since we're running out of time, I'll ask you to email us if you have questions. But most importantly, I want to thank all of our presenters, including Tom Workman, for sharing their work. This has been a wonderful learning opportunity for all of us, and thank you so much for your participation. We will send out a link to the webinar that will be recorded. Please feel free to share this with your staff on your projects who couldn't attend the webinar. And again, thank you all for your time.